Okay, whenever you're ready, Jean-Marc.
Okay. Hi everyone, and welcome. This is the London Global Cancer Week, so we are happy to sort of host this Canada session. So first of all, my name is Jean-Marc Bourque. I'm a radiation oncologist, an associate professor at CHUM in Montreal, and the immediate past chair of the Canadian Global Oncology Network. So I'm happy to sort of chair this meeting and have wonderful speakers that will be advancing equity in cancer care lessons learned from Canada for global communities. So we've got three wonderful speakers today, each of which will speak, and then we'll probably hold off for questions until the end. You can use the chat that we will monitor. And we also encourage you to open up your camera just to know that this session will be recorded and also hosted on the website for the London Global Cancer Week. So we've had a lot of interest, some competing sessions as well. So I think this session will be viewed even after. So our first speaker will be Dr. Nadine Caron. So Dr. Caron was born and raised in Kamloops, BC. Following her graduation from medical school, she moved to San Francisco to complete her postgraduate fellowship training in endocrine surgical oncology at UCSF. However, her love for British Columbia brought her home, and since January 2005, she has been working as a general endocrine surgeon at the Prince George Regional Hospital, as well as tenure-track faculty member at UBC's Faculty of Medicine, Department of Surgery, and teaching in the Northern Medical Program. She has served on numerous committees, including the province of British Columbia Ministry of Health Advisory Committee on Provincial Health Goals, members selected by the Minister of Health, province of British Columbia Medical Association on the Committee on Health Promotion, Native Physicians Association of Canada, and is currently chair of the BC Medical Association's Committee on Aboriginal Health. So we're very pleased to welcome Dr. Caron.
Thank you so much. I'm just going to load up my slides here. And we'll get started. Real honor to be with you here this morning. And I want to talk to you with respect to shifting equity expectations in cancer care in Canada, and not so much what we see in the hospitals or in the clinics, but actually moving upstream in terms of how we can enable equitable access to cancer research. Cancer research actually is what drives the decisions that we make and the care that's provided and the innovations that we see. Objectives very briefly are to just talk about the disparities that persist in the cancer care spectrum for Indigenous peoples in Canada, highlight examples of in Canada aim to address specific disparities in access to cancer research for Indigenous peoples, and to consider why knowledge generation and innovation can be certainly transmitted and shared globally. So over here in Canada, I live in the most westerly province called British Columbia, often referred to as BC. And BC has 5 geographically based health authorities, and I live, work, play, rarely sleep in the traditional unceded territory of the Lheidli, which is based up in northern BC. This health authority is about the northern 2/3 of the province, so it is quite extensive and sparsely populated. In Canada, we have 3 constitutionally distinct Indigenous peoples: First Nations, Métis, and Inuit. And that's important. So when I'm referring to projects, sometimes I refer to as Indigenous and others specifically First Nations. This is how I consider Canada, big country, lovely country, but there's this Venn diagram within it that include populations, rural, remote, northern, and Indigenous. And they do overlap. As a general rule, the more remote, rural, and northern in Canada, the higher the percentage of Indigenous peoples. So when you consider where I work in northern British Columbia, pretty much every patient I see, whether it's in the clinic or in the operating room as a surgical oncologist, consider themselves at least northern, if not all 4 of these within the Venn diagram. And I've had the honor of being in projects that aim to address celebrating these populations and figuring out cancer and cancer care and healthcare. These are called the Northern Biobank Initiative, Silent Genomes, and Marathon of Hope. So I will focus on the Indigenous perspectives today primarily. Quite honestly, because I am a member of the Sagamok Anishinaabeg First Nation, I have a personal interest in this, in addition to my professional interests that brought me home to Canada. There are disparities along the cancer spectrum for Indigenous peoples in Canada. I'm going to briefly list them because they're extensive. I think one of the main issues is that we have a paucity of data to actually confirm these and document these, and that's because of the absence of research or the limitations in access to research. There's disparities in the ability to even identify risk for Indigenous peoples in Canada due to the lack of access to family history and the applications of genetics and understanding of exposure to carcinogens, among others. Prevention disparities, which is a whole talk unto itself. Disparities in diagnosis. We generally, in the data that I have seen in British Columbia for First Nations, generally speaking, higher stage, higher incidence, lower survivor, lower age of diagnosis. Pretty much most statistics I've looked at are unfortunately we're on the short end of the stick. Treatment, the main thing is one of the major disparities is the options that we learn about in training and that you read about in the journals and what have been proven aren't necessarily choices that are available for those that live in that Venn diagram. And so we need to continually assess what is accessible versus what is actually used. And of course, outcomes. The disparities, outcomes are what really matters. And it's not just the outcome of the actual malignancy and survival or comorbidities or from the treatment, but the actual experience within the healthcare system, including cultural safety and racism. Access to research, I think, is a determinant of health, and I think people at this conference would understand this. We generate data, we get understanding. The understanding leads to better diagnosis, treatments, outcomes, and therefore, the more involved you are and more accessible the research is to you, the more likely that that research is actually going to be applicable to your community and people like you. And I think if you don't have access to that research, then people like Indigenous communities in Canada are less likely to benefit. The World Health Organization predicted this actually when they were referring to the genomic divide, and they basically quoted this quote from the World Health Organization is well known with respect to the necessity to ensure that the genomic divide was kept in check by how we distribute these resources. Canada didn't do a good job, even when we saw the value of precision medicine in oncogenomics and otherwise, but neither did the rest of the world. When we're involved in these elements of studies looking at Indigenous genomic data and the benefits of this, I think I saw more studies looking at the disparities rather than actually studies looking at successful stories of genomic research for Indigenous peoples. It talked about injustice, diversity problems, barriers, health inequities, and this genomic divide. In fact, at the end of 2022, Nature dedicated an entire edition not just to disparities and gaps, but actually a toxic legacy within science. And I bring this up because one of the projects based in Canada in the field of oncogenome or in genomics for Indigenous peoples was highlighted in this edition. So in the field of genomics and genomic research, I think this is the most elusive pursuit for equity in the spectrum of medical research. I think part of it's due to the paucity of Indigenous leadership in research foundations who decide what are the research priorities and where the money goes. There's a paucity of Indigenous identifiers in existing biobanks, not only in Canada, but globally. There's a paucity of Indigenous researchers and healthcare providers that I think would step into this space, address this, and really advocate for this absence and paucity of research. There's this lack of understanding or a fear of a lack of understanding of ethics using an Indigenous lens, and there are now necessary concepts of entities like Indigenous data sovereignty and data governance that sometimes paralyzes researchers and research ethics boards to actually move forward in the space of working with Indigenous peoples. And of course, there's Indigenous specific genomic data that are completely absent from reference databases such as NOMAD. So the concept of precision medicine is really halted and a massive disparity, which is, I think, catastrophic when I see the success in oncogenomics, particularly in projects like POG or personalized oncogenomics based in British Columbia. We have a Canadian hero, an icon, Terry Fox, and this is way back in the beginning, like why a surgical oncologist is involved in genomics. I'm not a genomic scientist. I don't do research in that space, but my role really is actually addressing and working on the equity element of this. I was asked to do a keynote address about 15 years ago to the inaugural Terry Fox Research Institute Research Day in British Columbia. And we talked about the concept of translational research, how these genomic scientists could come up with these amazing, amazing findings and translate that to the bedside across the street at the BC Cancer Agency. The bench to bedside phenomenon is something that I've always respected, and no one really questions this. But at the same time, no one ever asked what bedsides were getting to the bench. And that was a fundamental issue. So I think we need to reframe our thinking. Those people in that Venn diagram, and I think every country has a Venn diagram where people are inequitably treated with respect to these resources. This needs to change. One of the first things we need to do is consider the barriers and if they're even real, or are they perceptions of people that don't live and work in these spaces? Are they potential barriers that really shouldn't be considered barriers, but opportunities? I think so many times as an Indigenous person in Canada or as a healthcare provider in the North, we're referred to as hard to reach. And I think I recently said this, I think we need to reframe our thinking and transition this to being communities that are impossible to ignore. So there are steps being taken, like I said, in opportunities I have had the unbelievable opportunity of being part of, where there's research opportunities to address this. The Northern Biobank Initiative is based in British Columbia, that westerly province, creating a Northern Biobank for those living in the North, including those in rural and remote areas, but also embedded with that, hopefully next year, a Northern BC First Nations Biobank and the creation of a governance council to work in that space. The Silent Genomes Project is internationally known, which had multiple deliverables working with Indigenous peoples across the country, including the recently created and released Indigenous Background Variant Library, which is going to be used and is currently being used as a diagnostic tool for Indigenous peoples. And it's not available just in Canada, but can be utilized globally. And that was a decision made by the Indigenous Governance Committee that worked over the past 6 years to establish these kind of guidelines for the IBVL. And then the Marathon of Hope Cancer Centers Network. Marathon of Hope, again, referred to with Terry Fox as our national hero. He was diagnosed with osteosarcoma, treated, and subsequently went to work with respect to raising money for research in cancer. And as we started to create what we called the gold cohort in the Marathon of Hope with cancer centers across the country, aiming to sequence 15,000 tumors and get the clinical data of those individuals that would participate in this to create a national and international platform that could be used to fight this entity we call cancer, we realized that we need to be respectful and ensure that a Canadian project like this represented all Canadians so that it could benefit all Canadians. And that's where the Canadian Spectrum Working Group came into play. And so now when we look at the centers, you can see they're based in the south of Canada, which are urban metropolitan academic centers with genome sequencing, apart from the biobank up in northern BC, which is one step towards ensuring that this includes northern, rural, remote, and Indigenous individuals. Global applications, I think one of the things is that anything in science can be shared and learned. Indigenous leadership in genomics and precision medicine, we need to recognize it's not just happening in Canada. For example, the Silent Genomes Project had the International Indigenous Genomics Advisory Committee. Indigenous data sovereignty and governance has been worked across all of these projects that I've just mentioned, but it's also an international entity. And the United Declaration on the Rights of Indigenous Peoples actually focused on this. Canada ultimately adopted this and endorsed this, and the UN Declaration, Article 24.2, says that Indigenous peoples have the equal right to the enjoyment of highest attainable standard of physical health. Go back to one of my first slides. That includes access to research. Article 31 actually says that we have the right to actually develop our genetic resources, like biobanks. And I think one of the things is these projects are part of Canada's promise now. Finally, to just summarize it, there's a great quote at the Smithsonian Museum by Hugo Black. Great nations, like great men, I added, and women, should keep their word. So when it comes to promises like UNDRIP And when it comes to promises like equitable access to research, I think we need to keep our word and cross this gap. Miigwech, thank you. Merci.
Wow, thanks, Dr. Caron. That was incredible. I mean, you did a really good job at highlighting not only the gaps in our presentation, but like you said, turning barriers into opportunities for equitable access to research and care. We'll save the questions, so please note down your questions. We'll come back at the end. So we'll move on with our second speaker, which is Dr. Marc Gaudet, who's a radiation oncologist and associate professor at the University of Ottawa. He's originally from Moncton, New Brunswick, an Acadian. After training at University of Laval in Quebec City and University of British Columbia. He started his radiation oncologist career in Gatineau in Quebec, including work in the Abitibi-Témiscamingue region of Quebec. He is the head of radiation oncology at the Ottawa Hospital. In 2022, he became one of the first two oncologists ever licensed to practice in the territory of Nunavut and has since co-led the cancer care clinic in Iqaluit. He leads ongoing efforts to increase access to cancer care for rural and northern populations in Canada. So Marc, off to you.
All right, merci, Jean-Marc. So, I mean, I'm going to now switch gears a little bit away from the research lens and kind of put my clinician hat back on. So this is mostly the story of a clinical experience that hopefully will lead to improvements in equity, well, which has, I think, led to improvements in equity and will hopefully continue to do so, and will eventually lead to research. So I want to kind of tell a story of the importance of understanding and also the importance of in-person presence in 2025. So there's a lot of things that we have done that have involved actually moving us well providers around to get a better understanding and actually get a feel for being on the land, right? Which I think is an extremely important experience, especially in Inuit culture. To have you be on the land is a completely different experience and part of what we need to do. So I'll go through all of that. And I do not have any disclosures related to what we're going to talk about. So briefly in our objectives, I want to describe kind of the challenges and hopefully successes that we've had implementing a specialized oncology clinic in Nunavut, and describe how certain global oncology principles do apply in the Canadian context. So even though we are a high-income country, I mean, there are areas in Canada where social determinants of health are drastically different for many reasons, many to do with previous colonial efforts. And so, I mean, we are kind of unfortunately living with the fallout of that. And some of our global oncology principles actually apply in trying to create a more equitable care in the cancer space. I also want to describe kind of the importance of cultural awareness and mutual understanding and kind of lessons that I personally have learned through that process. So I do not have an Indigenous background and have come to this as a French Canadian from New Brunswick who saw glaring inequity in the care for our patients from Nunavut and wanted to help with that. And I mean, I've learned a lot of lessons and developed a lot of amazing contacts with fantastic individuals up north and have learned a lot, mostly from our Inuit patients and their families. So before I kind of go through everything, I always start by thanking people because we always do it at the end. So this is like a team effort with some of our team from Ottawa. So these are the oncologists who are now licensed to practice in Nunavut with myself. We have a fantastic team in Nunavut of GPs who actually are on site and permanent in Nunavut, as well as their chief of staff and again, our patients and their families. So the interesting thing about working up north is that things are much less challenging as far as getting initiatives off the ground. You might think the reverse, and Dr. Caron's talk kind of talked about barriers to research, but as far as barriers to implementing clinical changes, the line of sight in the north is very short as far as red tape goes. So if we get approval from the medical chief of staff, it goes to the deputy minister, the minister, things get approved, and it's very kind of straightforward. And we've always had an excellent rapport with government and teams up there at implementing new strategies or new initiatives, which is very different from working in one of the largest cancer centers in North America in Ottawa, and the amount of red tape that can come from working in a large academic center, as you can imagine. So the other thing, I mean, we've learned the most from actually our patients. So we've actually gotten quite close to many of our patients and their families. And this is just the family of one of my young patients who is about my age, who was diagnosed with a catastrophic pancreatic cancer in his early 40s and actually passed away in Ottawa. And he was one of the first patients we saw at diagnosis up north and followed him all throughout his cancer journey. And I mean, we have learned so much from these individuals and their families, and how their journey through cancer care is so different because of where they are from, because of their culture. And I think we need to be very sensitive to that, because James here, who's in the picture, is from a small hamlet of about 400 people, about 150 kilometers south of Iqaluit. And I mean, he was forced to basically live the last months of his life in Ottawa to receive care. And I mean, we did the best we could to adapt to that. But I mean, no matter how you spin it, most of the oncologic care is available only about 3,000 kilometers away from home, and oftentimes 2 or 3 days of flying time away from home to get cancer care. So for those of you on the call who are a little bit less familiar with Nunavut, I'll try to describe a very brief history of Nunavut. And I mean, if we know about our Inuit populations, they have an extremely long-standing history of an autonomous nomadic population, some of the most robust people on the planet, who lived in some of the harshest conditions you can imagine, and had faced very little interference from outside or from the federal government until, I would say, probably the 1950s, when there was significant interest in mining initiatives and different things like that in the north, which led to, I would say, some relatively disastrous colonial policies, which forced relocations of families from sometimes up to 1,500 kilometers out from communities in, let's say, northern Quebec, way up to the high Arctic, with promises of a great new life that never happened or never panned out. And many of the nomadic populations being forced into larger communities because their children were basically taken away and brought into schools in those communities. And many of the parents actually just followed, but not by choice. So just some honestly disastrous policies that were put in by the federal government. And that has resulted in, unfortunately, an ongoing, very significant inequity between Nunavummiut and the rest of Canada when we look at the majority of social determinants of health. So if it's access to care, physicians per population, just medium income, access to food. So over 2/3 of Nunavummiut live in a situation of food insecurity. They have lesser access to higher education, and the life expectancy for our Inuit population is now still about 10 years less than the Canadian average. There's significant infant mortality, overcrowded housing. So the vast majority of social determinants of health are unfortunately worse in our Inuit population, which is, to, I say, a very significant extent due to many policies that were voted through by the federal government many years ago. If we speak specifically about cancer care for Nunavummiut, I mean, this, and to Dr. Caron's point, a lot of the research that comes through is basically looking at how bad things are and then not really doing anything about it. So what we often see will be headlines like this, right? That say that Inuit have some of the highest cancer rates, honestly, on the planet. So our Inuit populations with Greenlandic Inuit actually have the highest lung cancer rates in the world, is what's reported. But then the big existential question is, well, what do we do about that, and how can we fix that inequity? I mean, some of that is due to smoking rates and different things and lack of screening, but like, what's the follow-up to documenting the fact that things are that they have a very high incidence rate or poor survival? Like, what comes next, right? And like, say, if we look at cancer statistics, Nunavut is kind of on its own as far as incidence of lung cancer. And the unfortunate reality is that most Inuit cancer care, or all throughout the north, involves significant travel for extremely long duration. So most of our cancer patients historically would have to travel down to either Edmonton, Winnipeg, or in our case, for the folks from Baffin Island, travel to Ottawa, often from diagnosis to oftentimes 4 months, 6 months, 8 months, to be in Ottawa away from home for cancer care, to get either chemotherapy or radiation or both. And that is the model that we have had for the longest time. And there used to be a dogma that if you were on systemic therapy or on chemotherapy, you could not go back home in between chemotherapy cycles, which means basically getting a treatment, then being in Ottawa for 3 weeks with nothing else to do, and then having another treatment 3 weeks later. So that was the old dogma that once you start cancer treatment, you are down south. And that has since changed, but no matter how you spin it, it involves a significant amount of travel away from home, away from your family, which unfortunately is a situation of drastic inequity between our northern populations and folks from down south. So, I mean, we can look at numbers all day, but does that tell the real story? So when we actually ask our Inuit patients how they feel about the treatment they're receiving, I would say down south, mostly in Ottawa. So this is a study done by some of our team in collaboration with a team from Nunavut. And what comes out of that is a lack of involvement in the decision process at time of diagnosis, lack of options being offered to them, and a lack of cultural sensitivity. So many Nunavummiut, when they're diagnosed with cancer, are seen in the emergency department in Iqaluit and then flown down to Ottawa being told, oh, you've got a spot on your lung. They're going to deal with it down south, and they don't really know what's happening. And they kind of leave home with their toothbrush, and that's about it. And then don't really know what's coming, right? So it's one of the biggest things that I think is a big inequity, is actually just describing to people what they have before they actually are forced to travel, because there was a significant proportion of patients who actually would fly down and pass away in Ottawa without actually getting cancer treatment, right? So having that initial discussion in territory before making a decision about getting workup for cancer, getting treatment for cancer, it was a very significant missing piece of the puzzle. So that led us to move what I call well providers around. So that was our solution to, there's a very limited staffing of GPs in Nunavut, and we felt that it would be good to have us well providers move around and actually provide care in territory, especially to hopefully provide further information at time of diagnosis, and also provide survivorship care in the north, and provide follow-up care so that folks don't have to travel back and forth to Ottawa as often. So we actually implemented an oncologic clinic in collaboration with the team up north, and actually started this way back now almost what's going to be soon to be 4 years ago, and actually had collaborated with many Inuit organizations up there to determine how we could best build this program, and started implementing this back in April 2022. And I always tell people the important thing is knowing what's available as well in up north. This is one of my favorite pictures of a perfect spot to build a campfire. But if you know anything about Baffin Island, there are no trees. So even if you want to build a campfire, you can't do it. So very important to know what the lay of the land is, and understand how things work. And I think that was one of the first things that we did is run kind of mock clinics with their GPs, and then implement our first clinics, which happened in 2022. And then as we got a better understanding of how things work, that has morphed into different initiatives that have kind of built on to what the clinic is able to do. And one of the first kind of glaring needs was providing information to patients at the time of diagnosis. We've also been able to provide home visits, which in the oncologic, like specialized oncologic world, for somebody who works in a large cancer center like me is not something that we usually do, but in Nunavut, that's very relevant. A lot of patients have trouble actually just getting to the hospital, and that's one of the things that we were able to provide advice to some of our palliative patients who were at home, and at least have a discussion about what was going on, and facilitate transition to palliative care. And like I say, that one of the biggest needs was providing this initial consultation, initial discussion before people were to travel down south. So we've had many members participate in that. Kelly is one of our radiation therapists who actually helped build a strategy to. So now what we've kind of baked into the system is a way to actually, if we're not in territory, build a virtual connection with patients before they actually come down. And we're now formalizing this as like our objective for 2025 and 2026 is to have everyone who leaves territory or who has a request for consultation in Ottawa, have a conversation with one of our oncologists and one of the GPs up there prior to actually leaving territory, so that they know what to expect and can make decisions about if they want to bring their family with them and have much better understanding of what things will look like in Ottawa. So that's our kind of lofty goal for 2026 is to implement a process where no one leaves territory without having had, or ideally no one leaves territory without having had a good conversation about their oncologic diagnosis and kind of what to expect down south. So that's what we've done with this essentially new patient evaluation. The other thing is initially this was run exclusively by a radiation oncologist, and we've since had medical oncology join us for the last 2 years. We've also had palliative care specialists join in and try to help improve pathways for Nunavummiut who receive palliative care at home in territory. So working with home care nurses and the team up north as well on that. We've also now run 4 community clinics. So in some of the most remote places in Canada, have had specialized oncology presence. So we've been to Pond Inlet now 3 times and had collaborated very closely with who was then their MLA for Pond Inlet, Karen, who kind of sums it up perfectly, saying it's very important that we are understood up here. And they are legitimately about 4,000 kilometers from Ottawa, so they're very much up there, up north. And I think there's kind of no way to understand it. Being out on the land gives you a much better understanding of how life is and how we can hopefully improve things. We have since run a clinic in Pangertung as well in January of this year. I was going to tell a story as well about the fact that about a year ago, we went back to the community where James, who is one of my patients, was from. Myself and 2 of my colleagues who actually are in the clinic, and one of our nurses from Iqaluit was supposed to come with us and actually was injured before heading out. But we actually hiked from Iqaluit to Kimmeroot, which is about 120 kilometers, and actually met up with James's family again to raise awareness about how difficult it is to access cancer care, and actually had raised some funds that we left in the community to facilitate family members traveling to either Iqaluit or Ottawa because they have very little funding to have family members join them when they are receiving care. So we actually raised funds for that, which I think, like I say, we wouldn't have been able to think of an initiative like that without really understanding the realities that they have gone through. And I mean, I was kind of blown away by how difficult that was for James and his family at the time of diagnosis. And like I say, we had followed him from the very beginning up, unfortunately, until he passed away in Ottawa. So again, being in territory on the land is a big game changer. So in the last, I'll try to run through this in a few minutes, but just to give you an idea now of what we've been able to achieve with the team in Nunavut, we have saved about 400 patients a trip down south. Which is a big deal. Like for somebody from a community coming down for a follow-up appointment can be a 7-10 day ordeal, being stuck in blizzards and what have you. So we've been able to provide care in territory for about 400 patients, about 40% of them from remote communities outside of Iqaluit. And if you know about Nunavut, every community is fly-in on Baffin Island, so there are no road connections between communities. So any trip involves travel by air, which can oftentimes be quite difficult and delayed in the honestly most of the year. Most clinics have been run by radiation oncologists or medical oncologists with our nurse navigator present many times as well. And we've also run some clinics with some of our residents as well. we've had patients in from most communities on Baffin Island, which is, again, saving people lots and lots of travel. So in a nutshell, I mean, the things that I wanted to communicate about how kind of global oncology initiatives or global oncology strategies fit in here is that I think what I've learned is like old methods of program implementation don't really work because there is honestly a sense of mistrust in the system, which I completely understand. And I think hopefully we have come to a point where like the time investment that we have put in to be on the land, to be in territory, has given us a lot of credibility with our Inuit stakeholders. And they are the ones who should be leading the way in these initiatives with us. So like I say, we've kind of reverse engineered it where we have been present, we have learned how things work. And research has really been a secondary consideration in the beginning because I think we needed to achieve that credibility and understanding before actually thinking of research. And we're now actually building research in a way that will hopefully improve care. So one of our residents is working on how we could reduce what I call idle time or basically wasted time down south, right? So that we can safely have people return home in between cancer treatments, which used to be dogma that we would not do that. So I actually want to measure outcomes of people who have returned to territory between cancer treatments and see if that's safe. And then again, I think this notion of medical risk and having people on the land back home is very important in understanding that. The unfortunate reality is that there's no dedicated cancer plan or structured cancer program in Nunavut, which is kind of the next step. The government has just changed, and I think the premier who has come in will be extremely favorable to building a dedicated cancer program, which is where people with global oncology expertise come in, right? It's a low resource area with extreme difficulties in travel, in accessing care. So I mean, these are all things that our global oncology specialists have dealt with elsewhere, not necessarily in Canada, but when it will come time to build a cancer program, I mean, we have some of these experts in Canada that will be able to help out and help coordinate building a program, which I think we're right on the cusp of. But again, this all has to be done in a way that understands the cultural realities of Nunavut and will be sensitive to that and involve our Inuit stakeholders. So that is about what I had to say. It's not just about a clinic. We can't just use old implementation methods up north. And I think there's actually an extremely significant benefit to us being present in person in territory. And hopefully we will see in the next few years a dedicated formal cancer program in Nunavut with both systemic and possibly radiation treatments being given in territory. So that was my talk. Sorry for going over a little bit.
That's okay. I will thank you. This is, I think, a very valuable experience, and we could show some examples of concrete sort of program implementation for, you know, giving our patients not necessarily all of the same amount of resources, but, you know, dedicated resources for everyone to sort of reach outcomes which are bringing care closer to home. So again, questions at the end, but I think in the interest of time, we'll just move forward quickly to Dr. Bourque, please take your time as well. She's a surgical oncologist and assistant professor at McGill University, a breast surgical oncologist at the Jewish General Hospital here in Montreal. She received her medical training and as well as her residency in McGill and an MSc in healthcare policy and financing at the London School of Economics Joint Program with the London School of Hygiene and Tropical Medicine in the UK. And in 2020, she went on to complete her breast surgical oncology fellowship at Duke University. Her clinical and research interests focuses on health services research, specifically breast cancer financial toxicity and disparities, as well as access to specialized care. So she directs the McGill Breast Cancer Outcomes Group and is a founding member of the McGill Global Oncology Program. She's also part of the World Health Organization Global Breast Cancer Initiatives that a lot of you would be familiar with to reduce the global breast cancer mortality. Dr. Bourque, to you.
Thank you very much. I hope everyone can see my slides. Yes. Okay, perfect. Good morning Thank you again for the introduction, Dr. Bourque, and it is such an honor to be here at the London Global Cancer Week and to be sharing the panel with my esteemed colleagues. It's a little bit of a different presentation, more conceptual, but I will be talking today about the critical issue of financial toxicity, which is a problem that affects many, but perhaps is poorly understood. Sorry, I just updated my Teams last night and I'm having trouble. So these are my financial disclosures, none of which are relevant to this presentations. So let's begin at the beginning and learn about how we define and measure financial toxicity. Anyone who takes care of people with cancer knows that cancer treatment has always involved trade-offs between the benefits of oncologic therapies and the inherent risks and toxicities. One of the often overlooked risks has to do with the financial burden of cancer care. And just over 10 years ago, Dr. Yusuf Zafar, who's a medical oncologist at Duke University, coined the term financial toxicity for this risk. FT is multidimensional and quite complex, but most of the time people tend to think about it only as the direct costs of cancer care. Increasingly, though, researchers have documented the prevalence of various aspects of financial toxicity among cancer survivors. This is a conceptual framework by Julian Witt and colleagues and is likely the most widely accepted classifications of the different facets of FT. You have your 3 domains, the material, psychosocial, and behavioral domain, as well as 6 subdomains. And of course, these various aspects can lead to a vicious cycle for our patients where the costs of care and subsequent financial and psychosocial impacts lead to potentially worse outcomes that are mediated by these adjustment measures. This in turn leads to increasing costs of care. And then this whole cycle, of course, is greatly affected by the disease and patient characteristics, but also affected by the broader health systems and geopolitical context, making it quite complex. So how then does one start to even measure financial toxicity? Measurement is usually the first step in evaluating the extent of any toxicity to then allow us to implement effective mitigation strategies. But for FT, this complex interplay of all the various factors that go into it make it really challenging to quantify it. It is likely for this reason that we have several different instruments for the measurement of cancer-specific FT, as you can see here. They're both full instruments as well as subscales within quality of life measures. And the number of items within each instrument can be as high as 42. So imagine having patients in your clinic having to complete a 42-item questionnaire just to measure the financial burden of their care. The EORTC currently is working on their full instrument, and it is planned to have a whopping 37 items. Nevertheless, this just shows you that there are quite a few resources out there for anyone who's interested in starting to measure financial toxicity in the clinical setting. Which leads me to the question of prevalence. So what is the global burden of this problem? We now have quite a few meta-analyses since 2016 examining all sorts of aspects of FT. And using somewhat more contemporary data here, I wanted to show you a global map of FT-related research. As you can see here, the lion's share of FT studies came from the United States. There are 30 out of 43 studies in the WIT meta-analysis and 19 out of 34 in the HESAN study, with most of them examining breast cancer patients. This is changing. So in the last year, there has been an explosion of studies coming more from low and middle income countries, which should show us a greater view of the problem. And while it may make sense that the American healthcare system imposes the greatest burden of cost of care on patients, cancer-related FT is certainly not an American problem. Ana Mesan and over at Harvard and colleagues conducted a meta-analysis evaluating the pooled prevalence of financial toxicity amongst patients with breast cancer. They found that via the use of various measurement instruments, 35.3% of patients in high-income countries reported financial toxicity. Of course, mostly from the US, but there were 3 studies coming from Canada in that meta-analysis. Compared to that, a horrifying almost 80% of breast cancer patients reported financial toxicity in low and middle income countries. At my lab, we are looking at this question in Montreal because the last study that evaluated this in Canada was published in 2013. I started my practice in 2020, bang in the middle of the COVID pandemic, and I knew we had a different story to tell, especially post-COVID with the cost of living crisis. This is the first of several studies that will be painting a detailed picture of cancer-related financial toxicity in the Canadian healthcare system. The study is still ongoing, and I did a very much an early data pull for this meeting, but here, as you can see, we are seeing approximately 45% of our patients, a little less than half, reporting some degree of financial toxicity in this early stage setting, with almost 1 in 5 women having moderate grade FT. So this is higher than the pooled estimate of 35% that we just saw. So what is it about breast cancer then that makes these patients at higher risk? Well, the fact that it largely affects women means that it could be harder to quantify the financial burden, as women have a higher share of unpaid work or carry out a higher share of unpaid work, such as caregiving. They also tend to have lower incomes than men, so that when they do work, it translates to a lower economic reserve and a higher vulnerability to this problem. In addition, breast cancer itself, like a lot of cancers now, have a complex set of care coordination needs, of frequent appointments, prolonged periods of adjuvant treatments, and survivorship phases. Subgroups that are particularly vulnerable are single, young people, female gender, ethnic minorities, unemployed or low-income groups, people who are living in remote or rural areas, and those with higher stages of disease at presentation. So we talked about the prevalence of FT. Now let's briefly talk about the actual burden. There's quite a bit of evidence examining the 3 main domains of FT, starting with the material domain, which is unsurprisingly what is most commonly reported. So this is Canadian data. In this Canadian survey study of just over 900 patients that included breast, colorectal, lung, and prostate cancer patients, data on income, out-of-pocket costs, and subjective financial burden were self-reported. The authors found that average monthly out-of-pocket costs were nearly 800 Canadian dollars, and that almost 15% of respondents spent half of their annual income on these costs. At the time, this was surprisingly comparable to the out-of-pocket costs of our American counterparts. Which brings me to the Canadian Cancer Society's special report on the economic burden of cancer care, which came out last year and had quite a resounding effect in the media. It showed that the societal costs of cancer care in Canada in 2024 were over $37 billion, with health system costs accounting for the largest proportion, of course. But what was more worrying was that the financial burden that was borne by the patients and their caregivers accounted for nearly 20% of that $37 billion. And most of this was in the form of out-of-pocket costs. Just as concerning were their future projections. So they estimated, the authors of that report estimated that in the next decade, in the next 10 years, the direct cost to our healthcare system will increase by 24%. And costs for patients, which includes out-of-pocket costs in that dark green there, will increase by 20%. They also showed that lung, breast, and colorectal cancers were the 3 largest offenders here, which is unsurprising given their prevalence, the increasing survival of these patients, and the costlier and costlier drugs being approved to treat them. Next, let's briefly touch on the psychosocial domain. And I say briefly because there is less research in terms of this, another gap. So what is the psychological burden of cancer-related financial stress? Well, several qualitative studies and at least 2 meta-analyses have evaluated this. And these 7 major themes are what come through in interviews with cancer patients. Patients report feelings of anxiety and worry related to financial concerns, fear and stress related to the future, guilt about not being able to provide like they used to, uncertainty about the future, and having to compromise on financial goals. And this also seems to have a negative impact on those health-related quality of life outcomes. So with this patient-level meta-analyses, Pangetsu and Rentz showed a moderate but significant link between financial toxicity and worse quality of life. So what kind of coping mechanisms do people come up with? This is the behavioral domain to deal with financial toxicity. And does it really have an oncologic impact? Does it impact survival outcomes? So multiple coping behaviors have been described secondary to financial toxicity. People may try to increase their income sources by going back to work sooner than recommended or extending their working hours. They may reduce or increase their daily expenses either by taking on more debt, selling assets, or not paying down debt as planned. They may seek financial support from friends, families, employers. They may hide their diagnosis and not seek any help at all. They may demonstrate non-adherence to recommended treatments or abandon it altogether. They may be forced to make major life decisions around having children or career planning. Or on the other hand, they may engage in constructive behaviors like preemptive financial planning, or they may have to negotiate with insurance companies or providers to actually reduce the financial costs of care. Perhaps the most interesting component of this for us clinicians is the treatment avoidance one. Cancer patients with financial toxicity in the study were 2.5 times more likely to delay care and just over 2.5 times more likely to abandon it completely than those without financial toxicity. And there are several strategies that are used, from not filling out prescriptions to foregoing tests to skipping appointments. This was a study of over 250 patients at a comprehensive cancer center in the United States, where they found that up to a quarter, so 24%, altered their medical treatment in some way to cope with the costs of care. We think this leads to worse oncologic survival outcomes, and it would make sense if patients are not adhering to treatments that would improve survival. And there is some evidence of this. To my knowledge, this is really the only study evaluating the link between financial toxicity and mortality. So this, again, from the US, looked at people with cancer. They cross-reference claims data and banking data. And they showed that patients with cancer who filed for bankruptcy in the US had a 1.8 times higher odds of death, risk of dying, than those who filed for bankruptcy but who did not have cancer. So that was pretty significant. But we don't know much more about this beyond this. There's a knowledge gap here, and our knowledge on what to do to prevent and treat FT is also limited. So we are also working on this to develop an understanding of cancer-related FT in our Canadian healthcare context. My lab is conducting the Fiona study, which is a prospective study which aims to provide a true map of financial toxicity for patients with breast, colorectal, and lung cancer, to try and see where the pain points are in that active phase of treatment and where we can have most impact, and then expand it to a pan-Canadian cohort to study the link with outcomes. So last part, I'll try to go through it rapidly: mitigation strategies. So financial toxicity is multifaceted, like we said, so any solutions that we want to implement need to be multi-layered as well. Screening is the obvious starting point to turn our model from a reactive to a proactive one and reduce the burden of disease. In both ASCO and ESMO recently published guidelines within the last year, I think, endorsing preemptive screening for cancer patients before treatment is started. But the reality is that this is not standard practice because there is no universally adopted screening tool, and that is a huge barrier to implementation. Like we saw, most tools are cumbersome and difficult to implement in a really busy clinic, but that might be changing. There are people working on this. The COST tool, which is the most widely used measurement instrument, was just modified to an abbreviated version that has been validated for screening purposes. It uses 2 out of the 12 items contained in the original COST questionnaire, and these 2 questions have a very high correlation with the full score. So it could really just be used in clinic next week if you want it. So multi-layered solutions, at the individual or clinic or even hospital level. We just talked about screening. Other very simple interventions can include conversations about the cost of care. And yes, it can be just as simple as that. We know that people want to talk about it. In a study, it showed that about 50% of cancer patients would like their providers to initiate conversations around the cost of care, but less than 20% of providers did so. But when they did, out-of-pocket costs were reduced and patient satisfaction was improved. Financial navigation is another big one and follows from the other one. If you filter clinicaltrials.gov and look for financial toxicity studies, right now most are evaluating financial navigation interventions, which include services and programs that provide guidance to people with cancer as they navigate their local healthcare system and their local communities to assign them to the appropriate support services. This can also help reduce financial distress and is being studied currently. At the health system level, which is extremely crucial and which will flow into the last policy level, cancer prevention is possibly the most efficient way to lower cancer costs. Things like smoking cessation, vaccinations, health promotions program. Screening is here again, but this time for cancer itself. So ensuring adequate implementation and access to cancer screening program. We heard a lot about the geographic disparities in access to care. Screening is a big part of that. Because early stage detection usually means lower cost treatment, usually. The drafting of national consensus statements or guidelines on FT screening can also help improve provider knowledge and mobilize resources. And finally, and possibly the biggest contributor to rising healthcare costs are drug prices, right? So value-based models to guide drug approvals and monitoring via health technology assessment agencies, for instance, can help mitigate as well some of those costs. And most importantly, I see our research community as such an important part of this health system level and also the policy level, is those investigator-led trials examining de-escalation of care, adaptive care, and non-inferiority evaluations of lower cost medications. And of course, the health system flows into the policy discussions with the goal ultimately to provide universal cancer coverage and avoid catastrophic health expenditures. And I think other policy conversations that are extremely important need to involve adequate employment or unemployment coverage and income protection. So in my province of Quebec, EI currently covers 16 weeks or about 4 months off work only. So we all know that even just the active phase of treatment can last a lot longer for cancer now, not to mention the survivorship phase. So I'm sorry for blowing through that at that pace, but thank you very much. Merci beaucoup. And looking forward to the discussion.
Thank you. That was wonderful. I think just quickly recapping, I think we have a really good panel sort of highlighting some of the issues there might be specific to or the context of our Canadian population. However, the issues and challenges and opportunities and solutions are not specific to Canada, and hopefully these lessons can be used to unify strategies globally. So we had increased representation, adapting to framework strategies was important, adapting our cancer program and policy for our Indigenous population, co-creating model, which is really important at the implementation level, example of optimizing a cancer system in a country that has 14 different healthcare systems. And then finally, the importance of intersectionality or the challenges of intersectionality in terms of financial toxicity, which goes beyond geography that we've often focused on in Canada, that goes to direct and out-of-pocket payments, inequities within the research questions we ask and the areas, but also the disease sites that we focus on, and the importance of good data in terms of producing good evidence-based policy. So on that, I will open up the floor. We will take a few extra minutes for questions from our participants. So please raise your hand, and we invite you to open your camera as well, because we're nice, because we're Canadians. So, and otherwise, also, if the panelists have questions for each other, otherwise, I will have some questions.
Sorry, Jean-Marc, I think participants may not be able to turn on their camera, but if they raise their hand, I can enable them. Otherwise, please just put your questions in the chat if you have any.
That's right. So I think I will start. It's sort of to all that. So we see that I think what's very common around global oncology, global health, whether it's Canada or abroad, are marginalized population, right? So it's sort of like designing a system from the fringe, we say. So how do we sort of group together sort of marginalized population in order to advocate more? So I would like to hear, you know, from you, what are the major barriers of doing so in protecting also the identity, the specific needs of certain vulnerable population?
Like, if I can speak to our experience just from Nunavut, I think one of the barriers, and I was surprised at the amount of pushback I would get saying, like, why are people from up north different? Like, why should we have a different process for people from Nunavut? And like, well, they're taking a week to get here away from their family, 3,000 kilometers away from home. Like, I think that by definition is different. And like, when we are down south, like, there's a lot of pushback that I was surprised about. And I think it's one of the things that we need to navigate and continue to point out the inequities, and the system is sometimes built to be inequitable, right? And we need to change that. And I think being able to point that out is important to have, like, our deciders know that, because otherwise we're not going to fix the inequities if we can't. Like, you need to make things different to make them equitable. Like, it's one of these weird constructs that I don't know if Dr. Caron has a smarter way to describe that than me, but I mean, it's one of these things that, like, I was always surprised how people would just put their back up and say, like, why are we creating a parallel process or a separate process, which we kind of have to fix an issue, right?
Yeah, I think a great point. I think it's just the fundamental challenge that some people have defining or understanding the difference between equality and equity, and just making everything the same when, for example, I breezed through those because I didn't want to belabor and start in Canada. It's like I started at 7 a.m. I didn't want to start with the massive disparities in the field of cancer for Indigenous people in Canada. But to treat people with those disparities equally makes absolutely no sense. It's basically, if you want to eliminate the disparities, first of all, I think shifting the target is one thing, and it's like a race. If you're doing a marathon and you're a kilometer behind, and everyone continues to run exactly at the same pace, you're never going to actually make up those disparities. The second thing is, it's the historical federal policies and the way that things rolled out to begin with that need to be addressed. And I think that's an additional layer on top of it. And it's recognizing that actually the goals need to be different. In the sense that Indigenous people have a right to establish what their own targets are. And when you say that you want to eliminate the gaps, it essentially means that you can be as healthy as us, you can live as long as us, you can have the lower rates of colon cancer as us, you can have the lesser toxicity as us, but you can't be better. You can't aim for higher. And that just fundamentally is so paternalistic and wrong. And I think part of it is a fundamental way to address these areas, these communities at the edge, is have people in remote areas being at the table and driving those initiatives, people, and working with people like Marc that are willing to be in those spaces and go to those territories and understand it. Marc understands it because he's been in those territories. But Mark, if you hadn't left Southern Ontario and like if you hadn't, left to go up there, it would have been this construct of what rural and remote and northern is. So I think making sure that the people that are living these inequities are at the table and driving them, I think is fundamental change that needs to happen.
There's also like one of the difficult constructs is this understanding of risk. So we also have a fair number of patients from Nunavut, especially men, who will say, I would just rather go out on the land and live my life and go out that way and not get cancer treatment, which is fine. And I think just understanding that concept is another thing that we have trouble wrapping our mind around, and how to approach that. I think we've gotten better at approaching that and understanding it. And I mean, we've had people medevac from being out on like on the land hunting and be medevac because they had a medical issue from their cancer treatment. But I mean, it's an informed choice, right? And they had a great time doing it, that being said, and then they were okay. But like that is kind of I guess person-centered care or informed care, as long like the man was very cognizant of the fact that there was risk of him doing that. But again, that is the way he wanted to run his life, and that's fine. And I think there's also that other aspect that it's sometimes about scaling back what we want to do, because people might not necessarily want the same treatment, or again want to be out on the land and have their end of life that way. That's not necessarily what we would want to do or expect.
Yeah, and I think there's a really important element of trust that you guys obviously highlighted. But I think Dr. Caron, like you said, I think having someone at the table in terms of advising or even creating its own sense of governance is something that you've experienced. It's really important. Is there any, we could go on forever. I think I have like so many questions, but people might not want to stream it if it's an hour and a half. But, I would like to first of all, I'd like to thank Arlie for organizing, and then Princess Margaret Cancer Global Oncology program for organizing this, and who are this year hosting our conference, which will be in March in Toronto, that I would highly advise you to check out the website and attend. It's a great conference. And also obviously our speakers, Dr. Caron, Dr. Gaudet, and Dr. Prakash. So, hopefully this is the start of many conversations we can have with people who are listening and people who will be listening at a later point. And feel free to contact us if you have any questions or comments or feedback. Have a good week, everyone.
Thanks so much.
Thank you, Miigwech.